So welcome, everybody. I'd like to add a little bit more to my background. As Kristen said, I am Lori Kaczmerek. I am Director of Clinical Education for Adhesion Biomedical. So that's sort of my disclosure, but also why I'm here tonight and speaking to you tonight. Also, past roles with the AVA Board of Directors, which I'll give that plug to. It's a great organization to be able to get involved if you're looking for building some leadership skills, or if you already have some strong leadership skills and want to participate. I'd love to talk to you and share my experience with you. But part of the reason that I'm here today too, and how I got to this position and where I came to Adhesion, I was a director of a vascular access team for about a dozen years. So like many of you that are on this call already, you're giving us, sharing some of that background about your experience. We all share this same challenge with bleeding and oozing with our vascular access devices. So happy tonight to be able to join in and share a little bit of knowledge that I have about this. So we're going to start off just talking about bleeding and oozing in general without, you can't do that without talking about the clotting cascade. So I'm going to be honest with you, this is just, it does make my head hurt to think about this, especially at this hour of the day. So I'm not going to go through all this detail. I think what we really know as clinicians, we do a really good job. Vascular access clinicians, I interact with people all over the country and internationally. Doing that assessment piece is really key. And we talk about this on the Vascular Access Facebook page. What do we do about the INR, the PTT, the platelets? What's the safest device? We do a good job assessing that, but there are still challenges with our, patients having post-insertion bleeding and oozing. And what's significant now, and even on, 2 weeks ago when we had the first IV League learning talking about hospital onset bacteremia, that we really need to now really pay attention to all of our devices and address the issues of bleeding and oozing with all of our catheters, because that's putting our patients at risk. So I'm more of a visual person. I like this kind of a graphic to really explain our skin and, blood vessels are protecting us from pathogens. And that's really the key here. But how does that factor in then to blood clotting? So again, visually, just understanding the need for our platelets to aggregate, to be able to clot and seal a break in our collagen is really important. And that doesn't, it doesn't matter whether we've scraped our knee falling off my bike, or a puncture through the skin, which is considered a surgical wound that creates the body's need to aggregate platelets and the fibrinogen, the proteins, all that go into forming a clot. Now, what's probably quite unique in this situation is in the image that you're seeing is that there's no catheter there. So what's going to happen is with all the functions working correctly, there will be eventually this fibrin matrix that aggregates there around and wraps and forms the scab that is then responsible for helping protect us from pathogens again. So I see a lot of this hospital onset bacteremia and the discussion about our catheters getting infected really tying in well to this discussion about post-insertion bleeding and oozing, because we really need to take a look closer now. What happens when we put that IV catheter in there? In most cases, with patients having a normal clotting mechanism, they're going to form a seal enough so that around that catheter, there's no post-insertion bleeding or oozing. Whether it's a peripheral IV or PICC line or a central catheter art line, patients can get bleeding and oozing. What's unique when you really look at this image is we're holding that channel open to a degree. And so in the absence of fully functioning platelets and a mechanism for clotting, patients are going to get post-insertion bleeding. So this is what we're stuck with, literally, no pun intended. And this, again, can happen with any catheter. What I see different and what's happening in this shift with hospital onset bacteremia being a discussion point is that we can no longer accept any of these scenarios. Whereas we tended to be a little more tolerant, I would say, with some of our peripheral catheters. If there was some bleeding or oozing, maybe we're going to take that catheter out in a day or so. we don't want to risk losing that IV, so we leave it like that. But really, it's putting our patients at risk for infection as well as failure of that catheter. So I'm here tonight to share some strategies, and not just my own, but all the strategies that we have, tools in our toolbox, so to speak. This is just a short list, and I know there are other things out there, but some of the, I guess, what I see or hear and what we recognize in standards and our guidelines, talking about just direct digital pressure. After an insertion of a catheter, that's generally the first approach to managing post-insertion bleeding and oozing, and probably the most effective. There is a tendency to do a short-term wrap or a tourniquet, but I recognize that that too has risks with it, especially since we don't have a good mechanism to understand how tightly we're wrapping that, what the longevity of that should be. It really should be short term. And so by standards and guidelines, depending on your catheter too, it's a different process wrapping if it's a peripheral IV versus a PICC line. And then we're really challenged if you have a central line or an IJ line. You're not really going to put a tourniquet around the neck, but sometimes we feel like we want to. Direct digital pressure above the insertion site can sometimes help. So it may be a combination of direct digital pressure over the insertion site and just above, so that you're compressing that vein and decreasing that flow. I've seen ice used, elevation. Ice, I think, comes with a risk. It's a, something I think more of a home remedy, but it is effective for helping constrict blood vessels and reduce post-insertion bleeding and oozing, but then you tend to see it come back or start after that ice process has stopped. Same thing with elevation. It's not always appropriate or applicable for some of our patients, especially if you're in situations where you have a patient that's being proned, or you can't move or mobilize a limb or an extremity. Topical thrombin and tissue adhesive are really the two key targets that I think really we need to focus on, and probably do look at this earlier rather than later, because again, the risk of failure of the catheter, if you have presence of blood there, not only from infection, but dislodgement. If you have blood there, by our standards, we know we should be changing that dressing. That increases the risk of CLABSI or of an infection just by opening that dressing up repeatedly, but it's also going to increase the risk of dislodgement or, completely losing that catheter. So these are, again, strategies, some recommended, some not. Direct digital pressure is really important in any of these scenarios so that you can get control of the bleeding and oozing before you're putting a dressing over that. This, I'd like to talk about using cyanoacrylate. Now, for those of you, obviously on the slides too, this is Secure Port IV. If you're not familiar with it, it's a tissue adhesive or a glue. And it's a catheter securement adhesive, but what's interesting is that it also has the ability to stop bleeding and oozing, and probably not something that everybody understands or recognizes. There is evidence about this, and this is just one paper that I do recommend that really helps understand the process or the hemostatic impact of cyanoacrylate on our catheters. Understanding too that this can be applied to all devices, including your peripheral IVs. So it's something to consider as, again, we start looking for strategies to manage post-insertion bleeding and oozing on all of our devices. But this is an experimental study on hemostatic effect of the cyanoacrylate, which again is intended for catheter securement. Dr. Zhang and associates wrote this. Just 2019, so it's been out for a while, but talking about cyanoacrylate or CA that can stop bleeding and oozing from that insertion site, its results in this study are safer for the catheter dwell period, again, because you're not opening and exposing or leaving blood or dry blood underneath that dressing. And that can lead to a decrease in the CLABSIs and also hematomas compared to conventional securement methods or options that we have available. They do speak about the mechanical hemostasis is 12 times faster than of thromboplastin in anticoagulated blood. So that's really significant. If you think about, even if you have that patient, maybe you had to do a skin nick and they have normal coagulation, but you're having some bleeding and oozing, how significantly this can impact And then all the way to those patients that are high risk, that have issues with post-insertion bleeding and oozing. Simply maybe 1 or 2, 3 drops of cyanoacrylate was statistically significantly more effective in managing or achieving that hemostasis compared to the control groups in this study. So I do encourage you to look at that when you're looking at options for treating or managing bleeding and oozing. And the ability to quickly achieve that mechanical hemostasis, it actually creates a physical blockade to halt excessive bleeding and oozing. So it's different than our thromboplastin products. So it's an option, certainly. And I'll show you, this is kind of a quick guideline that I talk about often, because the question comes up, well, when can I use tissue adhesive or secure port IV on a bleeding catheter, and when shouldn't I? And it's really, I just call it cut and dry. Your Drummond products are going to rely on that presence of blood. They're activated by a protein, and that's what makes them very effective. So if you cannot get hemostasis on your device, you've put the direct pressure, you've done some interventions, and you still have that bleeding and oozing, that's the direction you want to go. If you can get just a couple seconds of hemostasis, where you're, I tend to use my little demo boards when I'm walking around with captures to show. But if you can take your gauze away and you've got just a couple seconds of what I call dry time before you have presence of blood there, you have an opportunity to put a couple drops of glue and start sealing and getting that mechanical blockade to that bleeding and oozing. So it's been very effective. Like I said, if you can't get that hemostasis, you would follow that top grid, use the topical thrombin. But then when you are doing that first dressing change and taking that product off, that's a great opportunity then to get and put a catheter, the secure port IV, to seal that, because that line is going to be at risk for bleeding or rebleeding once you get some pistoning or micromotion of your catheters. As opposed to the other option, like I said, if you can get that couple seconds of hemostasis, that's when you would apply tissue adhesive. And we do what we call a dot and dab technique, especially if you've got a little breakthrough bleeding. So I'm just going to show you, this is a ampule here real quick. It is sterile and is dropped in your sterile field. The glue and the ampule is sterile, and you just push up from the bottom to open it, and you tip it down, and the glue is in that chamber there. But what we do with dot and dab is you get your dry, section or a couple seconds of dry time, create your drop and put your drop there. And now, like I said, right at the insertion sites where you're going to put that drop. That dot and dab technique that we're talking about is if you get some bleeding that starts coming back into that blood, we obviously don't want to mix the blood and the glue with that. So go ahead and put your gauze back on there and hold your pressure, and then take your gauze away. Observe that for a few seconds. You're going to actually take some of that glue back off, but some of it has already seeped and started sealing that track between the catheter and the skin in that dermal track there. And then you go ahead and put another dot. Watch the site. And again, if you see a little bleeding, you're just doing another dab. You're holding some pressure again. And that builds that sort of mechanical layer, and that creates that barrier or that blockade from any bleeding or oozing from coming out. That seals and secures the catheter. So you stop that pistoning and micromotion that might precipitate rebleeding. But the big benefit here is that it has an 8-log reduction. So it's gram-positive, gram-negative yeast and fungi. The process is also mechanical, how it kills these organisms within 3 minutes of contact with the glue. It's diffusing water from those pathogens, essentially killing them because they can't survive without water. So you're doing a lot of things that are protecting that catheter in terms of securing, you're stopping the bleeding and oozing, and getting rid of those organisms. And then as that glue cures, it creates a barrier and forms a barrier that pathogens cannot move or migrate into that space. So this, again, it's a very simple decision tree. It makes it very easy to understand the different approaches that we have. This is just a quick up close look, in case you couldn't see very well in my demo, just how easy it is to put a drop or two of tissue adhesive or secure port IV at the site to seal that. So that's my presentation, and I am welcome any questions that anybody may have. Open up your mic or put it in the chat. Any questions, Kristen, that have come in the chat?
We do have a couple.
Okay.
Patty would like to know what topical thrombins are indicated for use on vascular insertion sites.
We have lots at our disposal. You have StatSeal, or not Stat, yeah, StatSeal. So any of the products that you would normally use, the surgical, thrombin products can be used. Some people have a powder, some have disc form, but again, they rely on the presence of blood to be effective. So they are effective when you have that bleeding there, but this is an opportunity to stop the bleeding and stave it off right there. And I would check with materials management in your hospital too, because there are so many different contracts.
And then Terry was asking about a link to the study, and she was looking for the Zhang study, I believe.
Here we go. I'm going to put it up here. I can send the slides out too. I can leave it up here because it'll be on the recording as well.
I think that Brian was working on providing a link, so I don't know if you did the Zhang one or not.
I sent a link to a bibliography that includes the Zhang study.
Okay,
there you
so
go.
I'm all in there.
Are there any other questions?
Lori, I have a question for you.
Yep.
So I was in a conversation with a good friend, colleague, just yesterday, and we were talking about the buildup of, let's say every dressing change, you continue to put tissue adhesive over the site. Does it build up on the catheter or does it slough like it does with the skin?
It does both. The tissue adhesive releases off the skin as skin cells are naturally regenerating, and that generally starts about day 5 to 7 after application. And that's why reapplication is recommended when you're doing your routine dressing change. If you're putting too much on, and I'll be honest, when I started working with this, as a nurse, we're tempted to use everything like a unit dose.
Yeah.
So we were putting it all on, the entire vial, but quickly learned that was a learning curve. Less is better. And that's where we came. I can't take credit. My colleague Kelly, I think, came up with dot not a lot, or drop not a lot, one of those. But really starting small with your drops and really targeting your delivery to your insertion site, keeping the amount minimal. And if you do put too much glue on, or it just accidentally comes out too fast, you can spread some out for added dressing adherence. So you can move it away from that insertion site. Or like I was just talking about the DAP and, the dot and dab, you can wick some of it away. So if you've got too much on there, and we do that a lot more in the NICU population where you don't want to leave too much on, you can just wick it away. The glue stays liquid for a good minute or two. So you have an opportunity to sort of, I call it, recover some of the glue if you put too much on. So it's just whatever your technique is going to use. If you're putting too much on, yes, you're going to get buildup on that catheter. The remedy is generally just don't put so much on, and it will continue to slough off as your dressing changes progress, as that catheter stays in.
Thanks. Okay, we do have some more questions coming in now. This is great. Thank you, thank you, thank you. Have there been any studies comparing secure port to Surgicel or QuickClot? And
No.
Secondly,
Other than, Zhang's article does, in the in vitro and in vivo process, looks at the thromboplastin that way. But if you're talking on a human study, no, I'm not aware of one.
what about cost comparison? Have you guys done those?
I don't have the exact cost comparison. Brian might be able to chime in if you're the numbers guy with the cost.
Yeah, I don't know the exact pricing of the Surgicel or QuickClot, but usually they're multiple times higher. Yeah. Typically you'll see a tissue adhesive, the Secure Port IV product, being about a quarter the cost, but I don't have the exact pricing on Surgicel or QuickClot.
Surgicel was quite a bit more expensive when I was using it.
Even more than that. Okay.
Quite a bit. So, okay.
It's my understanding that products like Surgicel, they're more for like a wound. Like if they would go into a wound, and they're not meant to stay on for 7 days. So then you'd have to come in and and change the dressing sooner than you'd really want to.
There are some technology modifications or some product, and again, I'm not going to be able to speak directly to them. If somebody's on that works for these products.
Well, I don't, I just thought that's what
Yeah, but some have, especially if you have, I think one of the big challenge I know is for myself when I was doing vascular access and you'd have that bleeding line, you'd have to take that product off, within 24, 48 hours. But there's some added protection on some of the products that help keep the microbe load down. But it's not, again, sealing the site, and it's still going to need to be taken off. And when that's taken off, that line is at risk for bleeding or rebleeding, I call it. So then you're dealing with that pesky breakthrough bleeding that's still going to require that dressing change, the early unscheduled dressing change. There are studies, when we talk about studies, there's a couple studies out, and the link that Brian shared with a complete bibliography. There's a study from both Baylor Hospital and Houston Methodist, both independent studies, both replicated and decreased unscheduled dressing changes by over 50% because of the unscheduled, changes that happen with bleeding and oozing. So that combines to drive down that CLABSI rate or the infection rate. And that's why I think it's going to be real important to be continuing this conversation as we start talking about hospital onset bacteremia, because we're going to need to protect all these catheters in the same or similar fashion.
Good. So a little shout out to Sandra Bass-Gonçalves. They won SIVA's People Choice Award for their poster, and it talked about eliminating the PICC dressing change with the use of tissue adhesive. So she has her poster in the chat if anybody wants to see it.
Nice.
Congratulations on that. That's wonderful. Let's see what else we have here for you. Would you still apply a BioPatch or similar product if you use SecurePort?
That's a great question. And really at the organization's discretion, we have a lot more hospital organizations going away from using that patch. It adds to the, direct visibility of the site, and they're seeing decreased or zero CLABSIs. So it's with just tissue adhesive. So I think that's what's driving the change. But it's really, you can use it on top. We have customers that do. And no adverse event or issue with that. I'm a big fan for direct visualization of the site. You can visualize not only the appearance of the site and any evidence of bleeding and oozing, but also if there's migration of the catheter, especially with our PICCs, central lines and such. And you can, if there's still a lot of discussion about sutures. Sutures are always the challenge, especially on our IJ catheters, because they're putting them on to stop this catheter from pulling away, but then they're also bleeding and oozing. And sometimes that causes the unscheduled dressing change more than the actual insertion site bleeding and oozing. So you can put a drop of glue over each of those puncture sites on the skin to stop those from bleeding and oozing too. So lots of ways you can customize and use, but yeah, I mean, CHG discs and gels, you can use both with and then again without.
But if you think about it, if you seal the site, I'm just food for thought.
Yep.
Food for thought.
I'm right there with you. There's so many reasons not to. But I think we're still, a lot of organizations want to see their own study, their own outcomes. And I speak a lot about that, as I get the advantage of traveling across the country and seeing different teams. We're not all one size fits all. We have different patient populations. And so you really need to look at what's going on with your organization, whether you have a 24/7 VAT team, maybe you have a 7-day a week, but you're only, 6 to 6. And that changes some of the strategy or the mindset about how the approach is. So it's important to take a look at that individually as well at the organization.
Good. Is there a time limit for application from insertion? Can it be applied a few days later?
Absolutely. Yeah, a lot of times, for example, a hospital that's receiving a patient from an outside facility that did not apply tissue adhesive, absolutely, when they're doing that dressing change, put that glue on there, you want to protect that catheter. So there's no time limit. Ideally, you want to put it on when that catheter is inserted and start protecting it from ground zero and throughout the life of the catheter. But if that patient is in that situation, absolutely. It's really no different than you go to you transition a patient to a home care, they go to that standard of care or whatever that policy or procedure is with that organization. So that's
Right.
the same, it doesn't change.
Patricia is asking, and she said, she ends her question with, sorry, I'm new to vascular access. Patricia, we want your questions and we're so happy you're here. So your questions are, even us in vascular access for longer than we want to admit, we don't know everything either. So I'm glad for your questions. This says, what topical thrombins are indicated for use on vascular insertion sites?
Well, again, there's several products, powders or discs that can be used. I would talk first with your hospital's management or your organization system, with your policy and procedure. But you've got the Stat Seal is comes in a powder or a disc. It looks similar to a CHD disc that you're putting around the catheter. Applying some pressure. The powder one looks more like a round disc that you're placing the powder into that little round circle. So it achieves, again, that thrombin around that catheter and site to seal that bleeding and oozing.
Perfect. Oh, this is a question we get on a lot of the webinars with you. Does the tissue adhesive cause problems removing the catheter, sticking to the catheter, causing skin to tear upon removal? Great question.
It's a great question and happy to answer it. And it's easy to remove. Your process, whatever you do now to take your dressing off, is the way you would take your dressing off with tissue adhesive on there. The benefit, and in terms of skin integrity, this is used on micro preemies. I think our youngest is probably 22 weeks on up. They use it on umbilical catheter. So it's run the gamut of safety across all patient populations. The way you take a dressing off now, if it's walking it off with, say you use an alcohol, a CHG prep, or maybe even an adhesive remover, whatever you do to protect that skin, it's always essential to do that. And tissue adhesive should not change that process. What you will see is, especially if you add tissue adhesive beyond that insertion site, so you can spread some of that, like I said, beyond that insertion site to improve your dressing adherence, is that you're less likely to have repeated trauma to the skin from unscheduled dressing changes. So anecdotally, I can tell you that clinicians report this, that the dressings stay on, you're not putting extra tape to hold down the borders or the edges. That traumatizes the skin, because every time you're taking that off, you're shearing away the epidermis there. And then if you're maintaining your dressings for that 7 days, that's really critical, not only for eclampsia, but also for letting that hit, and keeping that skin intact. So hopefully that answers your question. It's really, I tell people all the time, we tend to want to overthink it. It's an adhesive, which is, a different type of adhesive that we already have on our dressings, but this is an opportunity to be a barrier for microorganisms as well as help the dressing stay on.
And I did a non-IRB study at home with that on a blister, and and actually I have a pair of shoes that every time I wear them, I get a blister on my pinky toe, and I put it on prophylactically as a skin protectant, and it's not FDA cleared for skin protectant, but it works really well. But with that,
Have you thought about getting rid of the shoes?
No, I love them. I love them.
Good.
Oh
Yeah.
no, it's only
It's
only the pinky toe. So
it is a barrier and protect. And the other thing too is, if you have a wound care clinician in your hospital, go speak with them. I'm betting that they use some different formulation of cyanoacrylate in some of the wound care that they already do, because it is a very effective barrier. So you can think of it as, if you're using tissue adhesive first on the skin and then putting your dressing on, you're putting the dressing on top of that glue layer as opposed to on top of the skin. So it really does protect the skin and works very well, even in our little kiddos, really well tolerated on their skin.
absolutely. And with that, guys, we're at the top of the hour. We want to thank you so much for being here. The one last question we're going to go with is this recorded? And can you see it again if you missed any part? Yes, it is. It will be on the AVA website under the education blog early next week. So you can go there. It's just a direct link to go click and watch it. Lori, thank you so much for presenting Adhesion. Thank you for bringing her here. We appreciate you guys so much, and everybody that stayed and listened to the presentation. Thank you.
Yeah, thank you for joining.
Tell a
Feel free to
friend.
reach out if there's any questions I can answer later too.
Thank you. Oh, Jiha had a question about hemodialysis, tunnel catheters, and oozing problems.
Absolutely.
Do you want to come on and ask your question, Jiha? Just open up your mic.
Hi.
Hi.
Hi. We use Secure Port over here also. The things that I've noticed with the tunneled hemodialysis catheters, we've been having some certain issues with controlling bleeding post insertion, requiring multiple dressing changes and then reaching back out to the IR team to assist with this. Is there anything besides the direct pressure? Unfortunately, with a heavy amount of oozing, the Secure Port does not seem to achieve hemostasis. So is there any other suggestion as far as with the dressing and the direct pressure that will help assist in reducing that post-insertion oozing? Typically, I will hold at the cut down insertion site and also at the catheter insertion site.
Yeah, that's a great question and a problem, obviously, that I thank you for bringing it up, because a lot of us will struggle with that. The question goes back to this decision tree that I put up here, is really, looking at, you've done all the pressure, the control. If you can't get that dry window, that's needs to be a different pathway, is what I call it. Because what you end up doing is, if you're dropping drops of glue into blood and then expecting it to cure, it's diluted. And so it's really not, it's going to be less effective. Just like if you have wet prep or any moisture on the skin, it's going to dilute it. So you need a dry surface before you put that on. It doesn't need to be a lot, but if you can get that dry couple seconds, I encourage you to start trying this, drop and dab technique, where you're putting your drop there. Don't be afraid to go back and hold pressure. And, you might be there for another minute or so and hold that pressure. Let that give an opportunity to keep building that mechanical barrier in there. That's a technique that we have, been learning as you all teach us, as we go, around and interact with all of you, as a technique that really has been very effective. So while it's not going to be something you can go in that really aggressively bleeding catheter that you just can't get anything, clean and dry for a few seconds, it is an opportunity. And, some of these larger catheters, we talk about drop, not a lot. So we're cautious about putting less on those types of catheters. If you're going and you're dabbing and you're taking some of that off, you may end up using that whole, it's 0.15 mils in there, but probably 10, 12 drops. I wouldn't be afraid to use that. There's not going to be any harm. You're going in there and building that mechanical seal. I would encourage you to try that and see if you can, get that hemostasis. I'm betting that you will. Maybe not on 100% of the lines, but it's a good investment in that care and maintenance of that line if you can protect it and mechanically block that.
Right. So sorry, along with that, with the dabbing, as far as with the, the sterilely included gauze, is there risk of lint and that remaining on the insertion site post application of the Secure Port? Normally I let that dry as best as possible, give it a long dry time, and then is there risk with dabbing that area with any kind of gauze material being left?
Your sterile gauze, I've not heard that that's an issue or a retention of that, because again, your first of all, the gauze that you have in your kit should be really a reduced lint, or the fraying type of a fabric. The glue, when you're doing that dabbing and dotting, is still liquid and you're taking that off liquid. So I've honestly not looked microscopically to see. I would think it would be no different too, that if you're putting gauze on that site and you're taking that gauze away from that bloody site, even without glue, that you potentially have some fiber there, because that glue is still, I mean, the blood is still very sticky and tacky. So you have that potential there, probably no different than glue. My question to you though is, when you talk about you're waiting for it to really dry, are you putting another product on top before you put your dressing, like a disc or gel that's necessitating that, or are you just going to your dressing?
As far as I know, we do one drop at the site. You wait 10 seconds for a second drop application. Generally, a drop under the hub, and then I use it around the perimeter and for under the Tegaderm Advance that we use. We are using bio patches still here. We've noted that if you don't have a long enough dry time, the bio patch does adhere to the catheter. So that's why I ensure that I have a well enough dry time at the insertion site prior to laying down a layer before the Tegaderm Advance.
Okay, that's what I was trying to figure out, if you were using, and yeah, it tends to tack on there as glue, things stick to glue, but be aware too that if you have to put that dressing on, first of all, I want to make sure you have the hemostasis before you put that on, before it all goes on there. But if you need to release that disc, it's just soak it with your CHG that you're prepping with at that dressing change, and that should lift off. It shouldn't be that much of a stick or attack unless you're wrapping or turning that disc around somehow. Should not, but I would love to speak with you offline if that's continuing to be an issue. We can, I know our time is limited here too, but
Well, there was one comment from a colleague that's on the call right now that they use quick clot to hold and they hold pressure 5 to 10 minutes for hemostasis.
okay.
A lot of bleeding and oozing, and then they apply the secure port, and they say it works really well. So
There you go.
that's one of the benefits from having people chat and say what they're up
Yes.
to. So guys,
I keep learning all the techniques from everybody that, has these, unique situations, and what you do. This is helpful. This is how we learn and how we can share.
Absolutely. Well, guys, this has been wonderful. Thank you. Thank you again, Adhesion. Thank you again, Lori. Thank you again, everybody that came.
Thanks.
And of course, my partner in crime on this, Dr. Jacobs. Thank you for playing with me. And guys, we'll see you in 2 weeks, every other week. And it is supposed to start at 7:30 Eastern time. Josh knows what the invitations go out at. I'm going to go work on that problem offline. But again, I appreciate everybody. Take care.
Bye.
Bye,
Thanks.
everyone.